Yes, ma'am.
No, ma'am. We are going live. 9:30. It's 9:30. We are going live.
Okay.
Sankalp sir, you can start.
Good evening all and good evening doctors. Myself Sankalp Sane, Marketing Manager from Innovcare Life Sciences. Welcome all to this interactive show, the Pundit Show by Dr. Ritu Santwani, supported by Innovcare Life Sciences. Today we have a very special guest on our show, the teacher of the teachers, Dr. Rishma Pai. Welcome to this Pundit Show.
Thank you.
It's important for us to understand what makes Pundit Show unique and special. It's a knowledge-sharing platform for experts as well as young doctors. The perfect mixing and mingling done by Dr. Ritu when it comes to strike balance between basic questions and advanced questions. Not only from India, but doctors from across the globe are getting benefited from this show. It covers all the aspects, be it gynecology, obstetrics, sexual wellness, women's health, medico-legal aspects, and others. With this, I will request Ritu ma'am to introduce our special guest, the teacher of the teachers, Dr. Rishma Pai ma'am.
Yeah.
What do you do?
Yeah. Thank you, Sankalp. A very, very warm welcome to our very own Rishma ma'am. Ma'am, these lovely roses for you. Hope you can get these fragrance for. Yeah. So friends, a very good evening to all of you. As all of you know, in this my Pundit show, I always invite a guest from our fraternity, our teachers who are having the immense knowledge. I think all of you agree with me on the fact that knowledge is the power. And I always believe that knowledge is always increases by the sharing. So in this September month, I'm inviting the our seniors and the faculties from our fraternity who are very knowledgeable. So, and I'm going to discuss on some particular topic on them, along with some secret tips. So, friends, I'm here, the Dr. Ritu Santwani. I am the host of this show. I am from the Pune, Oxford of India. So, our today's guest, I think, doesn't need any introduction. Our very, very own dear Rishma ma'am. So, Rishma ma'am is a epitome of the gracefulness and the beauty. A very, very warm welcome to you, ma'am. Ma'am is a combination of beauty and brain. So, Vaibhav, I have a biography of ma'am on the slides? Vaibhav? Yeah. So, this is a few lines for our very own Rishma ma'am. Ma'am is an honorary consultant gynecologist at Leelavati, Jaslok and Hinduja Healthcare Hospital at Mumbai. Ma'am has been in private practice since 29 years. Ma'am is the only Indian to serve as a president of all the 3 leading gynecological infertility and endoscopy organizations. Ma'am was a Foxy president. At that time, it was 35,000 gynecologists from all over the India. Ma'am is the only Indian selected on the board of the International Federation of the Fertility Societies, an organization of the fertility specialists from 68 countries as an assistant treasurer. She is the president of the MOX at present from 2020-21. She has been awarded from the esteemed fellowship honoris causa of the Royal College of Obstetrician and Gynaecologist, FRCOG London, in the year 2018. Yeah, next slide, please. Vaibhav, next slide, please. Yeah. Ma'am is the first Indian to has been appointed as a board member of the World Endometriosis Society. That's why we have chosen our topic today for this medical management of the endometriosis. Ma'am has a numerous awards. So I think I can read only the few awards. Otherwise, all my 45 minutes show time will go in reading the ma'am's awards only. 2019, ma'am has received the Worldwide Achievers Award, the Healthcare Leaders Award 2019. Again in 2019, Inspiring Gynecologist of the Western India awarded by the Times of India Group. In 2018, the recipient of the Midday Health Wellness Award as an icon in obstetric gynecology and infertility. Recipient of the Women Empowerment Award 2017 by IMA. Recipient of RK HIV Research Center Award for Excellence in Medicine in July 2017. Recipient of Bharat Nirmal Award for Women Entrepreneurship in April 2017. Recipient of 50 Outstanding Women in Healthcare Award 2017, recipient of Middle East Leadership Award 2016. Ma'am is a recipient of Women Achievers Award. Ma'am has also been awarded by the Newsmakers Best Doctor Award, the Great Women Achievers Award for Excellence in the Field of Medicine, the Nav Shakti Award. Besides this, also there are so many awards and the ma'am is having. So ma'am, a very, very warm welcome to you here. Yeah.
Thank you.
So,
Thank you.
yeah. Ma'am, with your kind permission, can we start this happy virtual hour?
Sure.
Yeah. Ma'am, before we go to the topic of this, regarding this discussion of the endometriosis, Weber, please, off the screen. Yeah, yeah. Take only madam and me on the full screen, please. Weber. Yeah. Ma'am, I want to know, ma'am, as you are a role model for so many of us. So, ma'am, I want to know, can you please share some success story? What is the success mantra of your this?
Oh God, I don't think there is any success mantra. I think it's everyone has a certain type of personality which one is sort of born with, and then one sort of fine tunes that. I've always been a very, very meticulous person. Right from childhood. I mean, my brother and sister joke about me that she was such a padhaku child, you're studying all the time, so serious about anything. Even if I had a project, I would make it perfect. School, everything. So I was always very particular. If it was a sports, then I had to be really good at it. I was a national skating champion. I was the state level swimming champion. So whatever I did, I tried to do, fully, wholeheartedly, very, very seriously. So I've never been frivolous person. I've never taken anything lightly in my life. I've always taken everything seriously. So that I think, and that has gone as part of my personality into my medical practice, into my commitment to Foxy, into my commitment to ESAR, into IG, to everything. Because when I'm given a job, then I really sit down. And I'm one of those people, even today, I'll sit down, make notes, I'll write down everything, I'll be proper. So anybody who wants any job done very properly, in order, meticulously, with discipline, they make me do that job. So I guess that has helped me, I guess.
Thank you. Are getting inspired by you. Ma'am, give us some tips for the young budding gynecologist. We all see you as a role model.
I think who were fantastic, but they were at a very high level. We used to just look up to them and we used to admire them. But we never had the guts to really be friendly with them or talk to them or share with them. I think the youngsters of today are much smarter, more confident. They have a very good relationship with their peers and their seniors, and they have now the tools to reach out to the entire world. In our time, we didn't have. I still remember when we had to research, we would have to go to the library, we would have to go to ICMR, we would have to beg, borrow, steal books. But here they have the whole world at their fingertips. So I think this generation is quite blessed. They're very smart. And all I can say is, compete with yourself. Don't constantly compete with others, run down the others. That's something I've found a little bit negative in the young people. Sometimes, they're so aggressive and so competitive. I feel compete with yourself, become the better version of yourself, improve yourself every day. Let the others do whatever they want to do and how they do it. So focus on yourself, improve yourself. Nothing works like, knowledge and, information about not only your subject, about everything around you. So have the energy, have the enthusiasm, work hard, and I don't think anyone can stop you from succeeding.
Wow, ma'am. Thank you. Thank you so much, ma'am. Ma'am, one more question. Ma'am, what motivated you to become a doctor?
Oh, God. Actually, quite surprising because that's not what I started out to do. I'm a very, person who likes to look at everything from both points of view. So all throughout my childhood, I wanted to be a judge because I thought I was a balanced person. If anybody says anything to me, I'll look at that side, then I'll look at this side, then I'll weigh the pros and cons. No, you are right, you're wrong. So I've always been like that. I thought I'd make a great judge. Of course, Rishikesh, my husband, feels that I would have been a very tough judge. I would not have let anyone go. I'm so strict, the kind of person I am. I would not, I would not get bribed by anybody. I wouldn't, I would be very strict and very tough. So he's like, good thing you didn't become a judge, you became a doctor, because I'm too proper along the track, So I think the only inspiration was probably my brother. My brother was the only doctor in the family, my older brother. And so once he went into that field, I think I kind of followed him because to look up to my brother and admire him. So yeah, that's probably what led me there. Once I went into medicine, I loved it.
Ma'am, so it is in your mind, ma'am, that you become a gynecologist only from the beginning? Once you've chosen this profession? Yeah.
Not at all. In fact, how children are rebellious. And my mother used to say only one thing: do any specialty, don't do gynecology.
Okay.
Because if you do gynecology, you won't have a life. You will have no quality of life. You'll be working day and night. So she would always tell me that, take a lighter profession where you can have some quality of life and things. But by the time I was an intern, I had already met my husband to be Rishikesh, who was a gynecologist. So it kind of just led into that. And of course, I came first in the entire, I was in KEM, GS Medical College. I came first in ophthalmology, actually. So the normal track was ophthalm because I've topped my entire university in that. But, I was meant to be in gynecology, so that's where I went. And like I said, I loved it from day one. So fortunately, yeah.
Okay. Yeah. Thank you so much, ma'am. Ma'am, I'm having the
asking me these questions. I've never spoken about all this ever.
Ma'am, this my program. I'm inviting the teacher of teachers. So besides the educational, we will get some inspiring tips from you also, ma'am. So that is also very, very important for all of us. Ma'am, ma'am, shall we start now the topic? Ma'am is going to discuss with us regarding the medical management of endometriosis.
I'll just share my screen.
Yes, ma'am.
But now I can't see the screen.
Vaibhav?
Yeah, okay. Give me a minute.
Yes, ma'am.
Yeah. Can you see my screen?
Yes, ma'am. Yes, ma'am. Perfect.
All right. Thank you, Ritu.
Yeah.
I'll go ahead
yes.
with my talk. So let's begin by saying that life is full of difficulties. We have to meet them, greet them, and defeat them. And I think nowhere does this hold more true than for patients who suffer with the problem of endometriosis. And so today we are going to be discussing on the medical management of endometriosis. As you know, a huge amount of women worldwide are affected by this very chronic, very troublesome problem of endometriosis. In the Asian women, as many as 20% suffer from some degree of endometriosis. Endometriosis, now there's a lot of focus on what exactly this disease is. It's a very unusual, very different from all other diseases. And there's a more and more focus on saying that it's an inflammatory condition. It is a result of interactions between various hormonal, immunological, and genetic factors. But the central role in endometriosis belongs to local inflammation. And you can see that these peritoneal fluid of these endometrial patients contains very high level of macrophages, immune cells, secretion of cytokines, angiogenic factors, growth factors, and all the inflammatory things like prostaglandin E2, COX2, all of them are found in a huge quantity in this particular area of endometriosis. Also, there is a contribution of oxidative stress, and there's an increased production of reactive oxygen species. So all markers of inflammation are present in endometriosis. Not only that, it is also having immunological aspects. It's an immune dysregulation with changes in the activities of cells which are involved in the immune reactions. You can actually see hyperactive peritoneal macrophages with altered phagocytic ability, which is actually representing another key point in endometriosis development. And this phagocytic activity of macrophages is mediated by the MMP, that is the matrix metalloproteinases. You can see natural killer cell activity is actually decreased significantly in endometriosis. And this immunosuppressive effect consists of the reduction of T cell mediated cytotoxicity. So again, immunological changes are taking place at the site of endometriosis. And of course, angiogenesis, we are all a little bit more familiar with, because we know that there are many angiogenesis-related factors, vascular endothelial growth factor, the receptors, and these are able to regulate the proliferation, migration, permeability of the cells. Interleukin 17A is emerging as a potent angiogenic factor. And all these angiogenic factors, such as TNF-alpha, vascular endothelial growth factor, all of them cause increased hyperpermeability of vessels, increase plasmatic proteins, induce the formation of fibrin, endothelial cell proliferation, and promote angiogenesis and fibrinolysis. So now you understand why endometriosis is so complex, because it's inflammatory, it's angiogenetic factors, it's immunological factors. So many, many things come together to produce or cause this particular disease. And you can see here how the COX-2 gene is producing COX-2 prostaglandins, the vascular endothelial growth factor gene is producing angiogenesis, the MMPs are working, extracellular matrix degradation is happening. So all these factors are coming together and producing this complex disease. How does it manifest? Most of us are familiar with the different types of pain patients with endometriosis suffer. It could be dysmenorrhea, chronic non-cyclic pain, dyspareunia, dysuria, many different types of pain, which is the main symptom. And of course, there can be infertility in the younger population. The diagnosis, unfortunately, the methods of diagnosis haven't changed much at all. From your history, classic history, to the examination, a good sonography tells us if there's, especially if the endometrioma is present, a CA-125, which may not be elevated significantly. Of course, if you do a laparoscopy and you take a histopathology sample, that's conclusive that there is an endometriosis there. And in some cases, particularly rectovaginal endometriosis, you may need an MRI. So for many years, we are working with these diagnostic modalities. Fortunately, now there's a focus on biomarkers for the non-invasive diagnosis of endometriosis. So what if we can just do a blood or a plasma or a serum or a urine test and confirm the presence of endometriosis? That would be fantastic. We could avoid doing a laparoscopy in many, many cases. And so they're looking at many different potential biomarkers, such as glycoproteins, growth factors, microRNAs, long-acting, long non-coding RNAs. Many of these are being looked into as the biomarkers for diagnosis of endometriosis. There's a lot of focus on newer sciences and technologies, such as proteomics. Proteomics is really a new perspective in the field of non-invasive biomarkers. They look at the proteins, so all the protein fingerprints used for diagnosis of endometriosis. There are 13 protein peaks were overexpressed and 5 protein peaks were downregulated in this group of patients. So just by studying the protein levels, you could actually determine whether the patient has endometriosis or not. Similarly, a lot of focus today, and you can see these are all the very, very latest studies from earlier this year itself, talking about genomics, which is really studying the genetics to try to find out whether there is some role that has to play in diagnosing patients with endometriosis. And you can see these patients have higher plasma concentration of circulating cell-free DNA, that is the complementary DNA in these patients. So microRNAs, again, there are many new articles on microRNAs. These are non-coding RNAs, and they represent major modulators of gene expression in a wide range of pathologies, including endometriosis. And this you can do by microarray. Nowadays, a lot of talk about PCR tests. You can actually find these microRNAs by that method, and they may be very desirable molecules for the diagnosis of endometriosis. So focus is going away now to more and more non-invasive methods of diagnosis of endometriosis, and see the number of biomarkers which are being worked upon. And I was a while ago at the World Congress on Endometriosis, and if you listen to the papers presented there, the kind of research that is going on in endometriosis, it is simply amazing. And this is the work that is going on study of growth factors, on glycoproteins, angiogenesis factors, apoptosis markers, hormones, leptin, prolactin, many other things like vitamin D, matrix metalloproteinases, like we said, study of proteome, study of immunology, so many different antibodies, all of these towards markers for diagnosis of endometriosis. So I think in the next couple of years, we really should have excellent non-invasive biomarkers to help us diagnose endometriosis. Classification, again, there has been confusion. And in the World Endometriosis Society consensus, which was held just a few years ago in 2014, they said that until better classification systems are developed, we propose a classification toolbox. So it includes actually a combination of classifications, because no classification is perfect. So involve the revised ASRM classification, the NZN classification, and the endometriosis fertility index all together, because some the revised ASRM classification ignores deep infiltrating endometriosis completely. But if you put them all together, then you may be able to classify your patients a little bit better and plan your treatment a little bit better. We all know that endometriosis had a huge impact on life, on sexual life, on relationships, on family life, performance, because of the pain, the discomfort, the dyspareunia. So everybody, every relationship, entire life of a patient is impacted by endometriosis. And so we have to treat this endometriosis. And the choice of treatment is, of course, going to depend on the age, how symptomatic she is, how badly spread the endometriosis is, whether the girl wants fertility, whether she's already been operating and is having recurrence of the condition, whether she's had treatments before or not. Even young girls, you know that from adolescent onwards, this condition may start. And the American College has given very specific guidelines for adolescents for endometriosis treatment, that always in young girls with pain, think of endometriosis. Don't just keep saying this is normal dysmenorrhea. Look at endometriosis as a cause. And then, of course, you treat them with basic painkillers. If not, then hormones, etc. And, already from the beginning, prepare them for the fact that it's a chronic condition which may worsen with time. So always try to give them treatment to prevent the progression of the condition. Avoid surgery unless it's required, because if you start surgeries very early, you'll keep on having multiple surgeries, and try to preserve fertility as much as possible for these young girls. So what are the options available to us for treatment? As you can see, we have so many different medications available to us, from hormonal to non-hormonal, painkillers, etc. And so let us look at some of these medications one by one. Most popular, most commonly used is the progestins. And you can see the progestins are the oral progestins like Gynaecologist, dydrogesterone, medroxyprogesterone, cyproterone. There are so many different progestins you can use. Even injectable medroxyprogesterone acetate can be used 150 milligram once every 3 months. So a whole variety of progestins is available to us. But today, the most popular appears to be Gynaecologist. So how does it really work? It is basically an oral progestin, 2 milligrams per day. It has been approved for the use of endometriosis. And it actually is a good drug because it lacks androgenic effects. So it doesn't have that many side effects like some of the earlier drugs used to have. It causes moderate inhibition of gonadotropin secretion. So a modest reduction in estrogen production. And that is why it's not severe reactions of estrogen deprivation that the patient gets. It has anti-proliferative, anti-inflammatory, and anti-angiogenic effects. So all the causative factors are actually suppressed with Gynaecologist. And now lots of studies are there for long-term use. This particular study just come out a few months ago, in fact, in May, said that long-term use, more than 15 months of Gynaecologist gives pretty good relief. It can be safely used, and it's a good alternative to even surgery. So what happens when you use Gynaecologist for a very long time? Studies have shown that there's a small reduction in the bone mineral density, but not much, not enough to increase fracture risk, not enough to have to give add-back therapy. And normally when the Gynaecologist is stopped, the bone strength and density comes back to normal in a short while. So that's not a major risk. There's no increased risk of cancer, no major negative side effects of long-term use of Gynaecologist. Another combination that we have for treatment is the estrogen and progesterone combination, OC pills. They've been used for a long time for endometriosis. They give good relief, but only for dysmenorrhea. Other kind of pain of endometriosis does not respond well to combination therapy. And of course, there's a risk of thromboembolism, impaired fertility because it's contraceptive in nature. And so some patients only are suitable for estrogen-progesterone combinations. In fact, this Cochrane review, which came out recently, said that there is insufficient evidence to make a judgment on the effectiveness of combined contraceptive pills for treatment of endometriosis. So right now, it's not the drug of choice. For patients who don't need fertility, levonorgestrel intrauterine system is a very good option. If you put it inside, slowly releases progesterone, lasts for 5 years, and produces amenorrhea in many patients, gives good relief for dysmenorrhea. So it's a good option for patients who are not seeking fertility. In India, we don't have right now, but it should be coming in soon, the Implanon and the Nexplanon, which are the subdermal implants. And these also release gradually progestin, eternogestrel, and they give contraceptive benefit, as well as they often induce amenorrhea and relief from endometriosis. Of course, like many of these other implants, they could have some irregular menstrual bleeding or weight gain, breast tenderness, which are all the side effects of the progestin molecule. So either the implants or the levonorgestrel intrauterine system, once you insert them just after the period, both of them give reasonably good pain relief and are pretty effective for a few years. So in well-selected patients, these may be a good choice. Another good choice, newer molecule which we've started using, is the selective progesterone receptor modulators. Drugs like mifepristone, quite easily available, inexpensive, 5 or 10 milligram per day. You can give it continuously, and that seems to have a beneficial effect for endometriosis. GnRH agonists happens to be one of my favorites for well-selected patients. They really cause good hypoestrogenism, amenorrhea in most patients, and give significant relief of pain, discomfort, heavy bleeding, etc., which these patients suffer from. Unfortunately, when you use it for long, more than 6 months, it causes too much bone loss and osteopenia. And so you have to give add-back therapy with small doses of estrogen or small doses of progesterone. You can use norethindrone acetate, which has been approved by the FDA for add-back therapy. But good drugs, you can use leuprolide, you can use goserelin, whatever you want, depot preparations, very, very effective. In India today, you get GnRH antagonist only as a daily injection. So obviously they're effective, but nobody can take daily injections. Worldwide now, US FDA has approved oral GnRH antagonist, the elagolix, at a dose of 150 to 200 milligrams per day for treatment of endometriosis. So when we get oral GnRH antagonist, it will be fantastic, not only for endometriosis practice, even for IVF practice, we use so much of GnRH antagonist. But at the moment, we don't have elagolix with us. What we do have is aromatase inhibitors. Again, many of us have used aromatase inhibitors for infertility patients. Letrozole 2.5 milligram daily actually reduces especially the extra ovarian synthesis of estrogens. And since older women mostly have extra ovarian production of estrogen, this is very, very helpful in older women suffering from endometriosis and its complaints. So letrozole can be used on a regular basis. So what are the ESHRE guidelines? ESHRE has said that we have to counsel women, always start treating them with pain relief, give them progestins, which is actually level A recommendation, antiprogestins, again level A, GnRH agonist, or contraceptive pills. All of these are effective drugs. And of course, young people, they've recommended do not use GnRH analogs, like we mentioned before, because of the bone loss in young patients. What about endometriomas? All this time, we've said that cystectomy is the best treatment, and probably even today, it is considered one of the best lines of management for endometriomas, particularly large ones. But now there's a growing body of evidence demonstrating at least some reasonable benefit in expectant management of asymptomatic patients with small, stable endometriomas. Not only expectant management, even Gynaecologist for treatment of endometriomas. It has been seen in this particular trial, again come out earlier this year, very recent study, treating patients of endometriomas with 2 milligrams of Gynaecologist daily or a combination of Gynaecologist with ethinyl estradiol. And it was found that patients who were on Gynaecologist significantly reduced the size of the endometrioma and had significant relief. So the point is to try to avoid surgery as much as possible, and otherwise the patient lands up with many, many surgeries in her lifetime. What about deep infiltrating endometriosis? Really no consensus on how to manage this. Patients really suffer a lot of pain and discomfort. And is there really still place for medical management in endometriosis, which is deep infiltrating? Typically, surgery is found to be the most effective treatment, but Gynaecologist seems to have some improvement even for these patients. So medical therapies have a role to play in all types of endometriosis, essentially. I think the most frustrating part of endometriosis is the recurrence, because huge recurrence rates, 6 to 67%, and people keep coming back to hospital because of recurrence of this particular disease. So remember, for recurrence, avoid preoperative therapy. If your patient is going for surgery, do not give her any therapy preoperatively, because it might mask the lesions. And not only mask the lesions, they may actually alter genomic process of endometriotic lesions and suppress the normal eukaryotic cells. And this may lead to an increase in the dyskaryotic cells in the endometriotic implants by negative selection. So pre-medical therapy, preoperative therapy with medical management is not a good idea. However, after you've done a surgery, for example, if the patient has large endometriomas, deep infiltrating endometriosis, you've done a surgery, after that, it is very good to put the patient on medical therapy, because it suppresses the ovarian activity, actually causes atrophy of the endometriotic lesions. And after the surgery, you can give her NSAIDs, progesterone, GnRH analogs, OC pills. You can put in an LNG IUD, or you can put, of course, the patient on Gynaecologist. So post-operative, a lot of benefit of reducing recurrence when you give them medical therapy. FOXI, our guidelines are quite clear in the management of endometriosis that management should be individualized. You have to give good pain relief. You have to prevent recurrence as much as is possible. Always try to do medical management first, and surgical management will be really only as a last resort in very well selected patients in expert hands only. Endometriosis surgery should only be done by experts, not by anybody else. So eventually, we know that there is no perfect therapy for endometriosis. And I put up this slide just to tell you that there are many cases of failure of medical treatment of endometriosis. Many people complain that their pain has not reduced. Some say that some amount of pain is still there. Some say pain was better, but it's come back again. So unfortunately, there is no perfect medical therapy also. So, women may have benefit, some of them may not have that much benefit. But unfortunately, even surgery for endometriosis is not fantastic. And this particular study compared medical and surgical therapy and found neither of them to be better than the other. So there was no great superiority of surgery over medical therapy. And so given the situation, we must try medical therapy earlier, because even surgery is not fantastic. So let me end with a few slides which give us a little bit of hope, because I believe that when the world says give up, hope says try it one more time. And so we always keep trying. We always want to give some more options. And fortunately, we have some good future therapies coming up, which we hope will help our patients. Anti-angiogenesis factors such as cabergoline. We already spoke about how endometriosis is an angiogenic condition, and cabergoline actually suppresses that and seems to reduce endometriosis. Statins, all of you use statins, atorvastatin, many households are taking it. This actually has inflammatory and angiogenic suppression factors in it. And this actually reduces the expression of the endometriosis causing gene. So simple things like statins may be used for endometriosis treatment in the future. Tumor necrosis factor alpha blockers, infliximab could be a monoclonal antibody against tumor necrosis factor, which actually helps suppress the inflammatory effects of endometriosis. Then there is peroxisome proliferator activated receptor gamma ligand. Sounds very complicated, but you all are familiar with the drug rosiglitazone. We have used it in the past. It has anti-inflammatory properties and actually helps reduce the size and volume of endometriotic lesions. And lastly, immunomodulatory agents such as pentoxifylline also have good anti-angiogenic effects and may have a role to play in endometriosis. So final words on the subject, and again, these are very, very latest conversations that are going on, that remember the role of pharmacotherapy in the treatment of endometriosis is across the lifespan of the patient. It is not for a short term or even a year or 2 years, it is for the entire lifespan. So start with simple conventional therapies, could be anti-inflammatory, progesterones, OC pills, agonists, GnRH agonist, antagonist, whatever it may be. You may have to give some emerging therapies like we just spoke about. And eventually we are moving towards modifying the immune and inflammatory milieu surrounding endometrial implant. So like I said, the future of endometriosis treatment may be quite different from the present treatment. And finally, let us rethink the mechanisms, diagnosis, and management of endometriosis. Today, laparoscopic surgery or exploratory laparoscopy may not be used to diagnose endometriosis. We can really diagnose endometriosis just by sonography, by a good MRI, and maybe by biomarkers. And just all the technologies that we have available to us. So invasive is going down, and less invasive procedures are being done, especially for diagnosis. Instead of the important sort of message is that instead of assessing endometriosis on the day of the diagnosis, gynecologists should consider the patient's endometriosis life. So again and again, the focus is on the fact that endometriosis is almost a lifelong condition. So don't diagnose the patient today and put her on medication today or put her for surgery tomorrow. Remember that her whole life she's going to have endometriosis. And so try to treat her with medical therapy in the first place. Try to relieve her pain and, suit the treatment according to her fertility requirements, her pain requirements, her age, her symptoms, etc. And of course, if she's requiring fertility treatment, then we may have to do a surgery and then do IVF, or in certain cases go for IVF directly. But eventually, modern endometriosis management should be individualized with patient-centered, multimodal, and interdisciplinary integrated approach. That's what modern management of endometriosis is all about. So finally, I believe, and I'm sure all of you agree with me, that the more we live, the more we learn. And the more we learn, the more we realize that we know so very little. Thank you. Thank you very much.
Vaibhav, please take the madam to main screen. Ma'am, thank you. Thank you so much, ma'am. It is a mesmerizing lecture.
Thank
you. Vaibhav, if there are any questions via Facebook, please take all that questions here. Ma'am, I want to know regarding the use of the cabergoline, your experience with the use of the cabergoline for endometriosis. Vaibhav, please take the madam on the full screen.
Yeah, I think all of us will have to focus now.
Lot of disturbance.
Okay.
I think all of us will.
Yeah.
So, like I said, I've specifically focused on trying to talk a little bit about the newer therapies and why they are going to play an important role in future treatments. Because all of us are very familiar with OC pills. We're all very familiar with progesterone. We've used it for many, many years. But we also know that treatment of endometriosis goes on for years and years and years. Sometimes they're starting treatment at the age of 18 or 19. How many years? And the patients ask us, how many years are we going to take this medicine? How long? And patients, if you tell them you have to take it for 25 years, they are not going to like it at all. So I think we all need a basket of drugs. Certain times in life, we can give them progesterone. Certain time we can put in an LNG IUD. Certain time maybe cabergoline will work. Certain times anti-inflammatory. So there's going to be a combination of drugs which we will have to use throughout their lifetime, because it's a lifetime disease, unfortunately.
Ma'am, turn on your mic. Turn on your mic. Ma'am, please turn on your microphone. Click on microphone.
Am I back? I don't know. I'm not able to turn the camera on, Ritu. I am not able. Okay. Here we are. Yeah. Can't hear you, Ritu, unfortunately. Ritu, I can't hear you. I can't hear you. I think we'll have to just chat because I can't hear you. Somebody will have to help us with this because my audio and video is all on, so I don't know what happened. With the headphones, I can't hear you. Totally lost the sound.
Now it's on. Can you talk?
Ma'am, now you can hear me?
Yes.
You can hear me, ma'am? Yeah.
Yes.
Yeah.
What happened?
Ma'am, it suddenly started raining here. I think that's why it's a problem here.
Yeah.
Ma'am, we are getting a lot of compliments for such an excellent lecture of you.
Thank
Ma'am, there are few questions. Some doctors have joined from the abroad. Ma'am, there's one question by Dr. Sumandeep Grewal. Writing, what is the best analgesic for severe dysmenorrhea of endometriosis in the girls who are not getting the relief by NSAIDs?
By?
NSAIDs, non-steroidal anti-inflammatory drugs. Yes, ma'am.
I think there's nothing like best. We have
Yeah.
to try a combination, and just giving painkillers upon painkillers may not serve the purpose, because you can't keep on adding 1 and 2 and 3 painkillers and injectable painkillers, because you have to find a better solution. So yes, if NSAIDs don't work, you definitely have to go on to additional therapies, maybe add the progesterones, maybe give, combination of OC pills, maybe add something. So you have to give a combination of drugs to give relief, not just keep increasing painkillers, because that will have too many side effects then.
Yeah. Thank you. Thank you so much, ma'am. Webo, please make the madam and me on the full screen. Why there are four this is coming? Ma'am, there is another question by Dr. Hema. She is writing, excellent session, ma'am. She has a query. How long to give the Gynaecologist in 18-year-old girl with endometriosis, with endometrium of a small size, less than 3 centimeter?
There's a lot of talks now about expectant management of endometriomas, because when it's a young girl of 18, you are worried that the endometrioma will keep on increasing. And if you don't give her medications, then poor girl will progress and it will get worse, which is a possibility. But at the same time, I would wait initially. The moment I see it, I won't start treating her. I'll see her. I'll measure the size, the volume, everything. Maybe call her back in 3 months again for another sonography. Evaluate. If the endometrioma is stable, if it's not causing her that much discomfort, just observe every few months and don't do anything else. Only if it's increasing steadily, if it's worsening her symptoms, then you will have to put her. And probably the first line today is progesterone or Gynaecologist as the first line of treatment. It doesn't have too many side effects, doesn't have androgenic side effects. Usually patients tolerate it well. So that might be the first line of treatment. You can definitely give it, like I presented you one study of 15 months. There are studies longer than that. Give it for, 1.5 years, 2 years, maybe change to OC pills in between, things like that. So that's how you'll have to pull her along.
Yeah. Yeah, thank you. Thank you so much, ma'am. Ma'am, most of the questions are related to the same. So thank you so much, ma'am, for enlightening us. Ma'am, if you permit, I want to ask you one more question on the lighter vein.
Tell me.
Yeah. Dear ma'am, could you please share something about your hidden talent, which all the foxes do not know?
Oh God, if you warned me about this question, I would have thought. I don't know. I think Foxy knows everything about me. I've been in Foxy for so many years. I think active in Foxy since many, many years. I really don't know what Foxians don't know about me. I already spoke about, and most people have seen some of my, desire to do many things. Like in when I was Foxy president, we started for the first time. Foxy has talent, so that was fun to do talent and create other things besides academics. So I do believe in having a life outside of gynecology. So sometimes when people see me in the evening, they said, "We can't believe that you're a gynecologist." I said, "See me in the morning. You'll see me in my sari and my salwar kameez, and I'm a proper gynecologist. But if I'm at a function or a party in the evening, I don't have to be in my typical gynecology look." So I think you can have a life outside of gynecology. You can be a very, very committed doctor. You can be very sincere, very focused, but that doesn't mean your entire life has to be gynecology. So I've walked on the ramp many times. I've done lots of shows just for fun, for friends, because I have lots of friends who are designers, who run jewelry, designers, boutique owners. So I walk for them sometimes for fun. I have a lot of lots and lots of different friends from very different fields. So I think you need to have a life outside of that, because otherwise it gets toxic 24/7. And for me particularly, because I've been president of all the organizations, I've been so committed to my field that I need once in a while a little bit of a break. So yeah.
Yes, ma'am. Yes, ma'am. Thank you.
Everybody that have a life outside of the medical profession. Yeah.
Thank you so much, ma'am. Thank you for giving your precious time and enlightening all of us. Once again, thanks to you, ma'am, from the bottom of my heart. Thank you for coming on my show.
Thank you. I enjoyed it. Thank you.
Thank you, ma'am. Thank you. Yeah. Over to you, Sankalp.
Yeah. Thank you so much. First of all, thank you so much, Rishma ma'am. And we are very happy that you have come on our show and discuss about the endometriosis and the treatment and its aspects. We have also one brand we have newly launched. It's a Dyno pill, which we have launched, 2 milligram of Dynogestin. And this is the area where there is a lot of need of understanding. There is a lot of need of patient awareness. This is what you have done today, ma'am. I'm very much thankful to you from Innovcare Life Sciences. Thank you so much, ma'am.
Thank you.
To you also.
Yeah. Okay, friends, we are winding off today. Ma'am, lecture was really, it's a mesmerizing lecture. Ma'am, see, we are not getting more. Itne sare queries aaye baad mein. Everyone is writing. It is a full, complete information.
Thank
So, friends, we are winding off today. For now, stay safe, stay healthy. Watch us again on tomorrow at 9:30 p.m. We are having Naren Malhotra sir with us. Okay, friends. Bye-bye. Stay safe, stay healthy. Bye-bye.
Good.